Welcome everyone to this training on the role of nurses in recognizing and addressing oncologic emergencies in leukemia and lymphoma, Disseminated Intravascular Coagulation, DIC, organized in partnership with the Princess Margaret Cancer Centre. Today, Cindy Murray, nurse practitioner in the complex malignant hematology program at Princess Margaret Cancer Centre, will address this second training in a series of 4. To get us started, my name is Alexandra Clark. I'm the Community Services Lead for Western Ontario here at the Leukemia and Lymphoma Society of Canada. Since there are many of you in the audience, we invite you to type your questions and comments in the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions. I will read your questions aloud at the end of the presentation during the question and answer period. Today's training will also be recorded. Therefore, you can watch it again on our continuing education platform. Before we begin our main presentation, I would like to share our mission and highlight some resources that might be helpful for you and the patients and caregivers you are supporting. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We listen attentively and with compassion to the challenges of the blood cancer community, including patients, survivors, and caregivers, and we can help assist them to the information specific to the type of blood cancer or treatment that they are experiencing. We also provide assistance in helping them to get organized, to manage and take charge of their care, and we can identify services that would be beneficial for them. Please visit bloodcancers.ca to find the contact information of the Community Services Lead in your area. We offer a continuing education program that you can join free of charge. You can register to one or more trainings that you can do at your own pace and receive an electronic certificate of participation. They are all offered by experts. We have 1,000 healthcare professionals that are using the platform, and there are 40 trainings available. The types of training that are available for you are trainings on blood cancer, treatments, psychosocial aspects of cancer, and more. For example, the first training offered in the series, Recognizing and Addressing Tumor Lysis Syndrome, presented by Graham Dossois, is available on this platform. We are adding trainings regularly. We also offer free materials to our healthcare providers. By visiting our website, you can place an order for materials that will be sent directly to your cancer center or clinic. Materials that can be ordered include disease booklets, service posters, palm cards, and much more. With this handy electronic form, you can order materials to be shipped to your location. It takes just a few clicks. If you have any questions, please reach out to the Community Services Lead in your region. We are always happy to help. Also available online are all of our educational materials, tools, and resources, vetted by experts for all of the main types of blood cancer. Our material is available in multimedia formats to address the variety of needs and preferences. They include digital disease booklets, fact sheets, podcast episodes, animated videos, and webcast recordings. Please visit our website, www.bloodcancers.ca, to find more. It is now time to introduce our speaker today, Cindy Murray. Cindy Murray is a nurse practitioner in the complex malignant hematology program at Princess Margaret Cancer Centre. She has more than 40 years of experience working with patients with acute leukemia and other complex hematologic malignancies. Over to you, Cindy.
Okay, thank you, Alexandra, for that kind introduction. Could we have the next slide, please? So hopefully over the next 20-25 minutes or so, I'd like to discuss, first of all, the normal physiology of coagulation before we move into disseminated intravascular coagulation, or DIC, where we'll talk about the pathophysiology, the clinical manifestations, the risk factors, how you diagnose it, what the treatment for DIC is, and then also included in that is nursing considerations. Next slide. So coagulation is the body's response to limit bleeding when there's been some type of tissue injury. So on the left-hand side of this slide, you can see an illustration of that normal process, which I'll go through in a little more detail. So the first step in the coagulation process is platelets aggregate to the site of injury and they form a temporary platelet plug to try and stop the bleeding. That platelet plug then attracts circulating clotting factors, that are floating around in the peripheral circulation, which then start off the coagulation cascade or the clotting cascade, where each clotting factor activates the next clotting factor and so on until ultimately it leads to the most important clotting factor, which is thrombin. And if you look at the right diagram on this slide, that's just a more detailed version of that coagulation or clotting pathway. I'm not going to go into too much detail about that because, to be honest, this used to give me palpitations in nursing school when we had to learn all the steps. What the takeaway and important factor is that when the most important clotting factor gets activated, and that's thrombin, thrombin is able to act on a protein circulating the blood called fibrinogen to convert it to fibrin, which then goes to that temporary platelet clot and stabilizes it by causing a more tightly meshed platelet plug. And that is our stable clot. But in order to prevent excessive clotting, we have to be able to break that clot down. So thrombin also has the ability to initiate a negative feedback loop that converts another protein in the blood called plasminogen to plasmin, which helps break down that clot into the different, into fibrin and all the other byproducts of that breakdown process. And that breakdown process is called fibrinolysis. Now, this is a very tightly regulated process to maintain homeostasis in the body. Next slide, please. But this process, of course, can fail every once in a while. And sometimes that failure can end up in this process called DIC. DIC is a rare but life-threatening condition, and it's characterized by accelerated clotting in the microvasculature predominantly. It causes depletion of the platelets and the clotting factors because it's developing more clots, and this leads to uncontrolled bleeding. So what you're seeing clinically is simultaneous bleeding and the development of clots. This is always secondary to some type of underlying disorder that triggers an uncontrolled activation of the coagulation system. So DIC can come on gradually, where the body has time to compensate for it, and it doesn't really manifest clinically, so we may not recognize DIC if patients aren't having any acute issues with clots or bleeding, or it can come on suddenly where the body just does not have time to compensate. Next slide, please. So clinically, what we see when this happens, we see that dual picture of excessive clotting and excessive bleeding. And as I said in the last slide, the clotting really happens in the microvasculature, and it can impair organ perfusion. So what we might see with some of the patients, they might go into kidney failure. We would see that manifested by elevated creatinines. Their urine output may go down. They may be having chest pain because they're having ischemia to the heart muscle. They may even have strokes because of some of these microvasculature clots. At the other end of the spectrum, if there's excessive bleeding, we're going to see obvious bleeding, bruising, petechiae. If there's enough blood loss, then patients may go into shock and develop hypotension. Next slide. So as I said in a previous slide, DIC is always secondary to some type of underlying clinical condition. And on this slide, you can see a list of those conditions. By far, the most common one is sepsis. And you can also see that malignancy, trauma, obstetrical complications, severe immune reactions, like in an incompatible blood transfusion reaction, for instance. So what I've done is I've highlighted the conditions that we see in our unit and on the hematological floors most frequently. So sepsis, malignancy, and immune reactions. Next slide. So I just want to go into a little more detail about DIC and malignancy, because of course that's the patient population that we deal with. It's more common in patients with solid tumors who have advanced malignancy, but it's also not common, but we can see it in up to 15% of patients who present with acute leukemias. And this incidence could even increase when we give the patients their induction chemotherapy. It's seen most commonly in two particular subtypes of AML, in acute promyelocytic leukemia, which we also know as APL, and in the monocytic types of leukemias. One thing that's important to note with our patient population, patients who have DIC and a platelet count of less than 50 have a 4 to 5 times higher bleeding risk than patients that have a higher platelet count. And that's significant because a lot of our patients either present or during induction have very low platelet counts. Next slide. So DIC does not always present clinically with a balanced clotting and bleeding state. Usually there's a clinical manifestation of one state over the other. So we might see more of a bleeding picture or more of a clotting picture. And this is really dependent on the underlying condition that's causing the DIC. So for instance, on this slide, you can see patients that have infections and maybe experiencing sepsis have more of a clinical picture favoring the clotting side of DIC. So those patients, we would want to be looking out for those microvascular clotting complications like impaired organ perfusion. Patients with trauma in an APL, on the other hand, present with more of a bleeding type of clinical picture. And I think when you see the case study that we're going to talk about, that'll become a little more apparent. Next slide. So let's go into a case study to just help solidify this information a little bit better. This is an actual case of a new patient with acute leukemia that did end up in the MHDU for a little while when we actually diagnosed her DIC. It was quite a few years back, so some of you may not have been here. This was a 45-year-old woman who came to the Leukemia Rapid Assessment Clinic for an initial consult because she had some blood work that was identified by her GP to have a bit of a leukemia picture. She had been having gingival bleeding, petechiae, and severe menorrhagia for about a week. So she went to see her GP, who did a CBC, and it was quite abnormal. You can see on the slide here. Her hemoglobin was only 55. For people who may not be comfortable with normal values, I've outlined those in blue font in the brackets. So this lady had a hemoglobin of 55, obviously quite low. Her white blood cell count was elevated at 22, and the majority of those white blood cells were blasts. Her platelet count was low at 40. Now, in the Leukemia Rapid Assessment Clinic, we always do some coagulation blood work on the patients. The coagulation blood work that's part of our routine blood work there is INR-PT, PTT, and fibrinogen. So when we got this lady's back, her INR was elevated at 1.9, her PTT was elevated, indicating that she had prolonged clotting. We'll talk about those lab results in the next slide in more detail. At the time she was in the clinic, we did not yet have her fibrinogen result back yet because the fibrinogen turnaround time is about 4 hours if you don't order it stat. So in the meantime, while we were gathering up all this information, we got a call from the hematopathologist who had looked at her blood smear and identified that the peripheral blasts were actually promyelocytes, which meant that she had an APL, or an acute promyelocytic leukemia, which, if you recall, is one of the conditions that can predispose a patient to developing DIC. So did she have DIC for sure? Next slide, please. So how do you diagnose DIC? Mostly it's a clinical diagnosis. There's not one single lab test that you can do that will tell you definitively that a patient has DIC. It's just sort of a clinical suspicion. Patients have to have an underlying condition that predisposes them. And we know with our patient here, she had acute promyelocytic leukemia, so she had the underlying condition. On physical examination, she did have signs of bleeding. She had the gum bleeding. She had lots of bruising. And then when we did the lab tests, that kind of confirmed that she did have DIC because she had a prolonged PTT, which represents that she didn't have enough circulating clotting factors in her blood to help it to clot. Her fibrinogen came back low, which meant that she didn't have fibrin, that factor that we need to clot our blood. Now, when you read the literature, they also talk about D-dimers, which look at the degradation products of a clot to let us know that the clotting process is being broken down quickly. But we don't do that routinely in our routine blood work when we have a new patient in the leukemia clinic. So I suspect they probably do it on the unit. Maybe you know that, Brian. Is that part of the routine blood work on the leukemia? Yeah, I don't think it is. But all the literatures will tell you that you should be doing that. So Our Lady pretty certainly was going through DIC with her APL. Next slide, please. So, you know, I find the longer I've been in nursing and medicine, people always want more definitive tests to confirm a diagnosis. It just doesn't seem to be enough anymore to have a really big clinical suspicion. So they're always trying to come up with tests that can definitively say that a patient has something or not. So there has been a scoring system developed to identify DIC or to diagnose DIC. It's been recognized by the International Society for Thrombosis and Hemostasis. One of the caveats for using this scoring tool is that the patient must have an underlying disorder that's associated with DIC. And what this scoring system involves is looking at those blood tests that you see on the slide here, assigning them a point based on what the value is, adding up with those points to get a cumulative score. And if it's 5 or more, then the patient is positive for having DIC. So if you look at the lady that I presented, we don't even have a D-dimer result on her, so I didn't even plug it in. But when I look at the other one, she scores a score of 5. So that would point to the fact that she does have DIC based on this scoring system. Like I say, I have never seen this scoring system used in my 40 years of working with hematology patients. I suspect where it's probably used more frequently is in the emergency department when patients come in with trauma. I suspect that's where it may be used. I don't know, do you ever see that on the floor, Grant? No. I didn't even know it existed until I started preparing for this presentation, to be honest. Okay, next slide. So what happened to our poor lady? So she has a brand new diagnosis of AML, just got diagnosed that day, has not yet been treated for it. We've decided we're going to admit her into the hospital, but we have to wait for a bed because you know what our bed situation is always like here. So she gets transferred to our unit, the MHDU, to have a platelet transfusion while she was waiting for the bed. We were giving her a platelet transfusion because she was bleeding. What happened when she got to the unit, she was assessed by the nurse as she started becoming hypotensive. So her systolic blood pressure was about 110. We saw her in the Leukemia Rapid Assessment Clinic, but it started dropping. And it wasn't related to sepsis that we thought of because she didn't have a fever. She was quite tachycardic with a heart rate of 125 beats per minute. While she was in the unit, the nurse noticed that her level of consciousness was decreasing. And notified the physician that she was having sort of a change in her clinical status. By this time, the fibrinogen level had come back and it was low at 0.8. So the physician ordered some fibrinogen to be given in addition to the platelets to try and increase clotting in her system. She also was sent for an urgent CT of her head because of a high suspicion for intracranial hemorrhage and because of her change in level of consciousness. When she had the CT, she was shown to have a pretty significant intracranial hemorrhage with a midline shift. So she was transferred over to Toronto Western Hospital to a neurosurgical floor to see if there was any intervention that could be done, because she was only 45 years old, hadn't even been treated for this new diagnosis of leukemia yet. The physician, before she left, also gave her a dose of Atra, which is all-trans retinoic acid, which is used to try and treat patients who have acute promyelocytic leukemia, because the only way that you're going to really reverse the DIC is to treat this underlying condition. We can support the patient with supportive care, such as, we'll go into that in a minute, but like the platelet transfusions and the fibrinogen transfusions to try and slow down the bleeding. But unless we can correct that underlying disorder, the DIC is not going to stop. Next slide, please. So what is the treatment strategy? Well, it's really to sort of stabilize the patient with supportive care until you can get that underlying disorder treated. So in our particular situation with Our Lady, who's presenting with more of the bleeding type of DIC, the plan was give her platelet transfusion, which we did. Also, the physician ordered some fibrinogen concentrate, which provides the fibrinogen that can be broken down into fibrin that can help the blood to clot. Sometimes patients are given fresh frozen plasma that contains clotting factors, thrombin, and fibrinogen to again assist with that clotting. FFP also contains albumin, which in somebody like this particular lady who's becoming hypotensive, and it helps to increase her blood volume. Back in the old days, I think before we started using fibrinogen concentrate, we used to use cryoprecipitate, which also has fibrinogen in it and other clotting factors. At our institution now, the blood bank doctors more favor the fibrinogen concentration because there's more fibrinogen in it. But if you were at another hospital, you may see cryoprecipitate used instead. Next slide. So what are the nursing strategies really to look after these patients who are in DIC? Well, mostly they're supportive and include monitoring of patients' hemodynamic stability, like our patient, watching her vital signs, noticing when they become hypotensive. So that was in a patient who presents with kind of that bleeding state of DIC. If somebody had maybe a solid tumor that was advanced, they might be presenting more with that clotting or thrombosis type of state of DIC. So you'd be wanting to look for, inadequate organ perfusion. In our particular situation with this lady where she was bleeding a lot, we want to avoid any procedures that might increase bleeding risk, like lots of venipunctures. We tend to do a lot of venipunctures to send off repeat samples of, say, some of the coagulation studies, but that can lead to a lot more bleeding as well, because at this point she didn't have any type of central line because it was a new diagnosis. Monitoring neurological status. So it was great that the nurse identified this decreased level of consciousness, that identified the bleed. Unfortunately, I don't think it would have made any difference if it had been identified any earlier for this situation. Provide intravenous hydration if patients are hypotensive, give the blood products as ordered. Assist with treating the underlying disorder, because again, that's really important if we want to try and control this DIC. So this lady was given Atra to try and help improve that DIC, but again, I just think it was just a little too late for her. So in regards to patient and family education, I mean, this was a very scary experience for this person. She's just being told, her and her family, that she's got this new diagnosis of leukemia, but then she's got this secondary complication related to it. So, you're trying to explain what's going on with this DIC, what the care plan is going forward, and really explain why we need to do such careful monitoring. It was I don't know if anyone remembers, do you, this lady? very sad situation because, as you know, we're not really staffed in the outpatient setting to spend one-on-one with a patient, and then you've got the family that you're trying to help through this as well. It was a very unfortunate situation, but a good example of DIC. So what are the take-home messages here? Well, DIC is a rare but life-threatening coagulopathy, and it can present with this simultaneous clotting and bleeding, but usually, depending on what the underlying condition is, there's usually a favor in one state more than the other. It's always secondary to an underlying disorder that overwhelms hemostasis. It's a clinical diagnosis that's supported by lab results and knowing that the patient has an underlying disorder. And the early recognition and treatment of the underlying disorder may improve outcomes. We really didn't touch on this much, but when someone presents with DIC, the outcome and the outcome rate is not good, and the mortality rate is pretty high no matter what the underlying diagnosis is. So that's it for the presentation. I'm happy to take any questions that you may have.
Thank you so much, Cindy, for sharing all of your expertise and insight with all of us today. It is now time for a question and answer period. So if you haven't done so already, please be sure to pop your questions into the Zoom webinar panel, into the Q&A box, and let us know if you have any questions about the content. While we're waiting for some questions to come in, I'll start with a couple of questions about registration, but just to double check first, are there any questions that are on site with you right now, Cindy?
Anybody have any questions or examples where you may have seen DIC? It's pretty rare, so fortunately we don't see it very often, but has anyone here encountered it in any patient? Yeah. Yeah. And that's true. I don't know if you heard it there, but Graham was saying his first introduction to maybe DIC was in a patient with acute promyelocytic leukemia. And that's a subtype of leukemia that does very well with treatment if you can survive that first couple of weeks and not have any bleeding episodes.
Perfect. Thank you. Question from the audience. Are there any preventative measures, or is there a way to prevent DIC?
When I was searching this, no, because there may be that chronic compensated type of DIC that's going on that could progress to an acute uncompensated. But the reality is, when I was reading the literature for putting this together, people don't go looking for coagulation studies in patients who have chronic DIC because you don't know that they have it, right? It's not until they present with really that acute picture where they're either bleeding or having clotting that you look for it. I mean, I would say in where we work here, which is a leukemia treatment center, we have a very high suspicion when a patient comes in and we think that they have acute promyelocytic leukemia, because that, you know, is probably the most common condition that we see in our practice related to that can cause DIC. But, you know, usually we don't know they have that subtype of leukemia for a while. This particularly did. But there are some hints, like we know that APL is more common in the younger age population. So she was only 45. So maybe the disease that acute leukemia she has, the subtype is APL because of her young age. So let's be on the lookout for that. But yeah, again, it's really hard to prevent this because of the relationship to the underlying disorder.
Perfect. Thank you, Cindy.
For
would you be able to repeat the question really quickly?
Oh, I'm sorry. Yeah. So one of the nurses in our unit asked, is there a platelet threshold? Like if we kept the platelets higher, would that prevent DIC? And no, because it's not just the platelets, it's also the clotting factors in the blood that are part of the problem. The clotting factors get all used up in developing those microvascular clots. So
We have another question from the audience. Do you have an inpatient unit you transferred the patient to once you recognized there was an issue with the patient, or to the emergency room? Or were they still in the ambulatory clinic?
Oh, you're asking a loaded question. We do have inpatient units. Unfortunately, we are always short beds. We will make beds, but that usually takes a couple of hours because we have to move patients around. At Princess Margaret Hospital, we're not a standalone hospital. We're part of a network, and we don't have an emergency department here. We would have to send our patients across the street to the emergency department where you don't have the expertise of the hematologist. So, I mean, in the ideal world, we would get that patient from the clinic up to the floor immediately. Ideally, we would be in a general hospital where we have access to like neurosurgery right away. So,
Perfect. Thank you so much for the answer. The next question here is, could you please explain ATRA?
oh, ATRA, sorry. So ATRA is all trans retinoic acid, and it's an agent that's used specifically to treat a subtype of acute leukemia known as acute promyelocytic leukemia, or APL, which is what our patient in the case study had. So the reason I mentioned that is because the only way to control DIC is to actually treat the underlying disorder. So by giving this lady ATRA, it's kind of part of the chemotherapy regimen that we treat these patients with. It was just kind of a last-ditch effort to try and, would this help with the leukemia really quickly to sort of stabilize the DIC. Unfortunately, it didn't work.
Perfect. Thank you so much. The next question from the audience, if platelet level is not incrementing amidst transfusion, does it mean that the patient is at risk for DIC?
So I think what you're asking is if we give a platelet transfusion, they've not gotten a big bump in their platelet count after the transfusion, does that mean that the patient is experiencing DIC? I think that's how to interpret it. And not necessarily, because it's not just platelets that you need to, help with the bleeding. You also need all those other clotting factors that are in the coagulation cascade. And the problem with DIC is those clotting factors have been used up in the development of the microvasculature clots. So no, it's not just the platelets. I mean, we would continue to give platelets, but we would also be giving blood components that have some of those clotting factors in them, as well as fibrinogen.
Perfect. Thank you. And we'll just have one more last question until we move on to our conclusion. Thank you for another great talk, Cindy, as always, from the audience. But the question is, could you comment on any potential utility or challenges with using tranexamic acid in the treatment of DIC?
Oh, that's a good question, actually. And I did come across that when I was reading some articles, and there was not a lot of evidence to support that it helped, not a lot of solid evidence, but there was some anecdotal reports that it might. So it's probably worth trying if you have it. I think when a patient is bleeding and it's happening as quickly as it was in the lady in our case study, you would just throw everything that you possibly could at this lady to try and control the bleeding. So given any kind of blood components, tranexamic acid, we would probably give that intravenously as well. We would just try and give anything possible to try and stop that clotting. But there is not a lot of hard evidence to support that helps, and it's not in any of the guidelines that I saw through the thrombosis and hemostasis group.
Perfect. Thank you so much. That concludes the portion of our question and answer. And thank you again, Cindy, once again, for being here with us today and for sharing all this information with us. We invite you to attend the next trainings of this series, the role of nurses in recognizing and addressing oncologic emergencies in leukemia and lymphoma. We have the syndrome of inappropriate antidiuretic hormone secretion, so SIADH, on Wednesday, November 29th with Matthew Somerset, and febrile neutropenia on Wednesday, December 13th, 2023 with Jane Lee, nurse practitioner, and Melissa Lowe. Next slide, please. Another event that could be of interest for you and the patients and caregivers that you're supporting is the new treatment guidelines for chronic lymphocytic leukemia on December 14th. You can register on our website at bloodcancers.ca/events. This event was made possible thanks to the support of AbbVie. And finally, I would like to remind everyone that we're here for the blood cancer community. Do not hesitate to order a tear pad for free or contact us if you need more information or support. Please note that a short survey will be sent to all participants after this webcast. We would greatly appreciate you taking a moment to fill it in, as it will help us to offer you the most valuable information in the near future. Thank you so much for being here, and have a wonderful rest of your day.
Thank you. Bye now.
Thank you.